online meeting of the Health and Social Care Overview and Scrutiny Committee. May I remind members that the meeting will be broadcast for live or subsequent broadcast by the Council's YouTube site, and that members of the press, public, may record and take photographs except where there are confidential or exempt items. Apologies. Can I ask both members and the scrutiny officers if there have been any apologies today?
No apologies. I've received no apologies, Councillor Brown. Okay.
Do any of the members have apologies for other people or not? I'm assuming no?
No, I don't.
Okay, right. Thank you for that then. So, action note matters arising. So, are members happy with the minutes of the meeting held on the 6th of November in as far as they're an accurate reflection of the meeting? And if so, I've got two matters of arising to bring up. Can I take it we're happy with the minutes?
Agreed.
Okay,
yes,
great. Thank you. So on page 4, the winter vaccine programme, the Birmingham Update COVID and Flu, which is the 16th of October meeting, members have been told that around 80 members of staff at Birmingham Solihull CCG have been redeployed to help with the vaccination programme. And therefore the further information that was requested at that particular moment in time isn't available. Do we have any indication, Gail, in terms of when it's likely to be made available to us? Or can we find out when that information is going to come through?
No, not at
Okay.
the moment. We don't know.
Okay, thank you. And on page 4, primary care access, a response to the letter we sent to Paul Sheriff, Birmingham Solihull CCG, requesting further information was circulated to committee members on the 30th of November. Did everybody pick that up? Okay, I'm assuming the answer to that is yes, because otherwise we'll get Kale to recirculate it. Okay, so the first actual item we got is the Boots Birmingham Urgent Care Treatment Centre programme, and we've got Richard Mendelson and Helen Curry who are to present that for us. I think just want to make sure people are aware we've just got a fairly busy programme today, and we've just got 25 minutes for this slot. So if people could move things forward in a timely manner, that would be really appreciated. So Richard and Helen, it's over to yourselves.
Thanks, Mick. Hi, Gail, are you able to put the slides up for us, please?
Oh, Kerry, Helen Kerry's going to do.
Thank you, that's wonderful. Thank you, thanks everyone. I'm Helen Kelly, I'm Director of Acute and Community Integration at Birmingham and Solihull CCG, and Richard Mendelson is also presenting this item. There's Richard. Hi.
Hello, yeah, thank you.
Hi.
So Richard's our Chief Medical Officer, so I'll lead the slides and then I'll bring Richard in to add additional comments in, if that's okay, and we can take questions at the end.
Thank you.
Thank you. Kerry, next slide. So in terms of context, last December 2020, we updated the committee regarding a change in model around access to urgent treatment centres. This includes Boots. And that's the access to all urgent treatment centres across Birmingham and Solihull is via NHS 111. NHS 111 enables, if people phone NHS 111, it enables them to get the advice and treatment at the right time, and if necessary they can be booked into a time slot into the service that's appropriate for them. That includes GPs, urgent treatment centres, same-day emergency care and emergency departments. So it's convenient and also gives a time slot rather than people showing up as and when. The model has now been embedded and we've seen a shift in patient behaviours and understanding. And next slide, please. So in terms of across Birmingham and Solihull and for Boots, there are no walk-in centres, they're all called urgent treatment centres, and the face-to-face model has shifted from that walk-in approach to a telephone consultation and then a booked appointment as required. We have seen patient demand increasing at emergency departments, which has led us to look at what we can do in the short term to ensure there's extra clinical support in each of those emergency departments. And we've adapted the model, therefore, to where the demand is presenting so that we can meet people in a timely fashion. I'm going to bring Richard in as a jobbing GP to give a little more context around that change in model.
Yeah. Thank you, Helen. Yes, Councillor Brown. So I'm the Chief Medical Officer in the CCG, but I'm also a local GP part-time in the south of Birmingham. And I think there is some controversy about this, but actually we have had to make a shift in the way that we're providing care. And my experience is that patients are now adapting to the way that we've moved the way to access care, so that and actually I have to say, in light of Omicron, we'll have to do this more with patients that actually we have to talk to them on the telephone and start to use different modalities. So face-to-face, definitely if they need it, but also dealing with things remotely via video, and quite a lot of the time just on the telephone. People are happy to do that, particularly in a younger demographic, and this is the group that uses this kind of service locally in the city centre. They're much more used to remote working, using the internet, and approaching health services in a different way.
Thanks, Richard. Next slide, please. So in terms of Birmingham Boots urgent treatment centres, there are currently very low numbers of face-to-face appointments. So on average, you can see Monday to Friday 9, Saturday 11, and Sunday 5. So in terms of patients who are allocated to the Boots urgent treatment centres, 80% are managed over the phone and never physically go to the building. So it has a level of convenience, because if we look back to when people were walking in, the demographic attending Boots urgent treatment centre was mainly working age women between 20s and 30s, with the highest number of conditions related to skin conditions, minor coughs and colds, and ear infections. So predominantly now for I-111, they can, if it's required, receive an electronic prescription, so they don't need to even see somebody face to face. So that brings a level of convenience as to what Richard was saying is important really for this demographic. So there's no walk-in consultations that have been offered for over a year, and that's the same across all of our urgent treatment centres. And really the change in the name is really important to an urgent treatment centre, as NHS England is setting these centres out to be alternatives to using emergency departments. And when we look at Boots, that location will never really meet that service specification due to the location, the facilities and the opening hours, as it's a store. Richard, is there anything you'd like to add on that?
Well, I think, yeah, I mean, clearly the data that we've got shows these primary care conditions, and they can be met in a different way. And if you do want to walk in, they can be met via pharmacy. Pharmacy have consultation potential and with rooms, not just in Boots but in others. There's also a local practice round the corner if that's necessary. But really, I think the best way to access care would be go through NHS 111 and get these conditions managed over the telephone, or indeed booked back to your own GP. So as a GP, when I do a surgery, I have two slots in my morning, and they get booked automatically by NHS 111 with a short report about what the patient needs, and that works really well. So like the clinical assessment service, I can send prescriptions to the pharmacy that's nearest the patient. And recently I've had patients who aren't in the area, and I've been sending scripts to different places. So if you're in the city centre and you needed a script sent, that's perfectly possible to do with the kind of new technology that we've got to transfer prescriptions to where the patient is and what they require.
Thank you. And next slide, please, Kerry. So the proposal for the future is when we take all of these aspects into account, so the change in the access, the level of activity, the need that we're seeing at our emergency departments, is that Boots funding and possibly the staff are reinvested into additional capacity at the urgent treatment centres, so that telephone and face-to-face appointments can be met, and also some of that clinical resource into the emergency departments to meet the demand where people are presenting. That will make sure that we're using the resource wisely, both clinically and financially, to meet the demands of the population. So we've also had a discussion with the provider of Boots Urgent Treatment Centre, and they also see this as the most appropriate way forward really for that model. They're a national provider, and that's what they've been doing in other areas. They've been reallocating the resource mainly into the emergency departments to meet that demand that's presenting there. Richard, would you like to add anything?
Yeah, so this as a nurse has been a nurse-led service, and actually what we want to do is provide a greater range of services in an urgent care and treatment side, and actually you need a wider team, so you need to be working with healthcare assistants and medical colleagues, so that actually you can deal with more complex conditions, while the kind of conditions that people have been coming through can get, as I said, can dealt with in a different way if needed. But it's a much better way to provide emergency and urgent care for patients through the urgent treatment centres.
Okay, thanks. So next slide, please. So it's really important that any service, any changes in the service are communicated effectively. What our intention is that we would deliver a full suite of communications activity, both physical and digital, so that local people are aware and signposted to alternative services such as mental health services, 111, pharmacy, etc., self-care. The push to NHS 111 first is a national initiative. It's not just locally. So there is a national campaign that I think has just commenced really. There'll be adverts and posters asking people to phone 111 before it's that talk before you walk, so that they are directed to the right area, particularly as what Richard said, to avoid any infection risk, so the Omicron, but also other infections that are potentially around the corner, for want of a better term. So it is that element of ensuring that people get to the right place at the right time. We are conscious that Boots was used by a lot of businesses in the city centre previously as almost sort of an informal occupational health type service. So we would make sure that we'd targeted all the business sector and third sector, so they understand how to signpost and access care effectively. We also look at vulnerable communities and ensure that they are understand how to access services to meet their needs. Okay, so that's a whistle-stop tour of our overview of Boots. So I'll open up for questions. Thank you.
Okay, thank you both for the presentation. That was really interesting. I found it quite valuable. So I've got three people who want to ask questions. The first of which is Councillor Tilsley. So over.
Thank you. Good morning, Richard. Trust you well. We've spent some time over the last couple of years looking at alternatives for the Boots walk-in centre, realising that it does provide a service for the city centre, although the usage is quite low. Would you care to comment on possible alternative locations?
Yes, thank you, Councillor Tilsley. We have spent a lot of time looking at boots in effect, and I think now the current changing model would mean that we wouldn't be looking to look for a different city centre location for the UTC. We'd be looking at moving that resource into each of the emergency departments. So currently the provider of Boots UTC has added some additional resource into the Children's Hospital to be able to meet the demand there, and that's working really well. So what we would be looking at is reallocation of that resource into the emergency departments and into the existing UTCs. So there's Katie Road and the other UTCs across Birmingham.
Okay, Helen. Okay.
Okay, thank you, Councillor Tilsley. Councillor Pocock.
Yes, thanks, Chair, and thanks, presenters, for the summary that you've given to us. This committee over the years has been very strong in championing the business case for a walk-in facility in centre of Birmingham, which has a very particular pattern of demand, of course, a sub-regional city, a commuter city, packed full of visitors of various sorts, whether working, visiting, shopping, through the busy days we used to have pre-COVID. And I think the valuable role of a convenience store, should we put it that way, where you could drop in and talk about issues concerning your health, was highly valued. Recognising the present situation, the footfall in the city is very different. Public access to primary care is very different. I can understand the decision that's been put to us today. But I want to take the discussion a bit further forward, because we're looking at an evolving service, primary care. The way primary care is offered to the public is changing, as we all know. And to some extent, we're elected members, we get this down the email and down the phone all the time, that primary care appears to be more remote than it's been before, less accessible than it was. And we can again understand why that's happening at the present time. At the same time, the COVID circumstances have really highlighted the value of walk-in facilities. We walk in vaccination, we walk in for testing. The trick has been actually to make walk-in the way to get people to take up services they wouldn't otherwise do. So there are two lessons, I think, out of the COVID. One important lesson is the absolutely crucial value of a facility where you can just walk in and talk to a health professional. So I'd just like to flag the need for us to discuss further as a committee, working with you, how we can evolve a model for primary care in a city like Birmingham, which contains within it a means by which people who happen to be in the city centre for whatever reason for a day can find their way to primary care support by walking in and talking to people. Now, and obviously telephone, online, accept all that as well, but there is quite clearly, in the evidence that's come forward through COVID, an indisputable and very powerful need for an element of walk-in service. So I don't know quite how we want to finish this off, Chair, but I think it would be important for us to flag the decision you're making and to note it and to recognise the circumstances for making it, but at the same time to recognise that there is a gap that will be created as we move forward, that we need to look at filling in some way over the next few years, over the next 5 years or so, as we develop a new model for primary care generally, that this walk-in element should be a feature that we try to reconstruct. And the urgent treatment centre isn't quite right. I think the morphing of walk-in centre business case to urgent treatment centre naturally leads to the decision that you've made. But the business case for walk-in, if anything, has been reinforced by the COVID experience. So I think this is a discussion to continue. It's a debate to be developed further, and I'd like to flag for the future the need for us to talk through with you. I hesitate to say in a post-COVID era, because I don't see one coming. But as we settle into life with COVID, that we can evolve a form of primary care that will allow a walk-in facility to be part of it. And that's the comment I really wanted to make. Thanks.
Okay, thank you for that, Councillor Pocock. Before I brought Councillor Islam in, I just wanted to when McCann will stay on, to say I think we should look to note this report and possibly look for an expanded discussion on the linkages between walk-in and virtual centres, because I don't think it needs to be an either-or option. I suppose I just wanted to sort of ask a question in terms of, do you feel that the majority of your people that actually were using that facility are people that actually work in Birmingham and would possibly use your facility rather than the GP, because it purely can be accessed by the telephone or by computer, as opposed to having to physically go to a GP practice, which may be more inconvenient for them in terms of their lifestyle choices?
Yeah, Councillor Brown, I think you've summarised that exactly. That's what's panned out in the data, that it was the convenience when people were working in the city centre and we weren't operating this type of model pre-COVID. People were walking in and it was for those minor conditions, or I've forgotten my prescription, you know, those types of points. But actually the change suits that demographic more, to be able to just phone up and have that digital appointment, which is convenient, and that seems to have stacked out. And as you can see in the numbers, because people are triaged or assessed over the telephone, and sometimes 80% of their needs are met then, and a small proportion then come attend for a booked appointment, which is safe, and actually offers a level of convenience as well, because at least they know they've got a booked appointment as opposed to waiting in a crowded waiting area.
Yeah. Okay, so thank you for that. Councillor Islam.
Thank you, Richard and Helen, for your presentation. Just only for one minor point to clear, because you mentioned about the person allocated to booths, the ETC from NHS 111, 80% are managed over the telephone. What about the 20%? Do you think they refer to the emergency department, hospital emergency, or the walk-in centre? This is the only clarification I need to know. Thank you.
Yeah, thank you, Councillor Islam. Those people are booked to attend, and sometimes they even choose, they may be booked to attend, and it may be that they need to go to an emergency department. At that point, they're booked there, or they can be booked into primary care. So there is a mix of people as to where they're booked. Or the other bit is we have seen the other UTCs outside of the city centre slightly busier, in fairness.
Thank you very much. Thank you.
Okay. Councillor Debbie Clancy, you're next.
Thank you. I know you talked about, Helen, I think it was you talked about getting the prescriptions obviously available for patients to their nearest. I represent Longbridge and West Heath. So I'm south of Birmingham, and myself and the MP's office, we've had an increase in concerns from residents, lots about housing, but more about how their issues are affected with gaining access, getting through that NHS phone call, getting onto progression to get access to the things they want. We have a very large Boots store in Longbridge, but there is no pharmacy facility in that store. And we've seen an increase in queries around that, because yes, there are other chemists around, but I just wondered if we've got, when you think about the population of a certain area, are we functioning as we should with those phone consultations face to face if we can? Are they getting the access to the actual prescriptions as they should in that sort of area? I mean, I know there's a lot to cover there. What I'm saying is, do they get, when they finally get to the service they want, whether that's phone to phone, face to face, NHS, directed to ED, are they getting the prescriptions that they need? Is there any data around that to say, yeah, pharmacists are not overloaded, they are functioning as they should for those services, for those demands? I don't know. It's a bit of a broad question, but it's one I wanted to raise, because we have a large Boots with no pharmacy. They've got no license for it, and I cannot understand why as a store they don't. And we've got little pockets of chemists.
I mean, it's an interesting point. I don't know if Richard wants to come in actually, because you've got experience.
How the pharmacists are operating on the outskirts of the city is what I suppose I'm asking.
Yeah, so thank you, Councillor Clancy. I think looking at this in the round is important, and this isn't an excuse, but we don't have direct responsibility for commissioning high street pharmacy services. But we expect that with the formation of the integrated care systems, that's probably coming, and we'll probably have a closer relationship in the first year, and may even at some point be more directly responsible through the integrated care board. I mean, I wasn't aware there was no pharmacy in the boots, so I think it's something I can raise with NHS England about access to pharmacy, because clearly it's important. You need both, don't you? You need access to someone who's going to recognise what's needed and ensure that there's a prescription, and then send it to where you are. So we wouldn't necessarily have the data for, if you like, access around for that population, but it's something we can raise with the people that we talk to around this. Because you're right, if you might want a prescription to go to a particular place, but if there's a bit of a desert in pharmacy provision, then that needs to be looked at. Given what's happened over the past few years with 100 hours pharmacies, I mean, I haven't been involved in this for a long time. Quite a lot have been developed in different places, but it's something I'll raise for that area, if that's acceptable, and get back to you.
Yeah.
Okay, thank you for that. Councillor Islam and Councillor Clancy, you still got your hands up? Are those sort of legacy hands?
Legacy, I'm just trying to work out to get it down.
Okay, that's cheers, don't worry about that. I just wanted to ask a quick question, and this is a follow-up to Councillor Clancy's question about boots and farmers having a pharmacy inside. Of the boots that I know, they've all got pharmacies in. So it'd be interesting, I think, for the committee and myself to know how unusual it would be for a boots not to have a pharmacy. And I'm thinking the boots. I
don't think I'm incorrect there, but I'll double check it. I'll double check and I'll let you know. But I don't think I'm incorrect. That's what I've recently been told, and I haven't double checked.
Yeah. I thought if you'd said that was probably true, but it might be worth them checking for us anyway to see what the situation is on in-store pharmacies. Okay, does anybody else have a question?
Chair, this is Councillor Fowler. I think it's all been said for me. Thank you.
Okay, right, that's great. So can I thank you, Richard and Callie and Helen, for today. It's been a really valuable presentation. I think picking up on Councillor Pocock's earlier point, it might be useful if you arrange to come back in the new municipal year to have a discussion on the combination and the needs for a variety of walk-in and virtual urgent treatment centres, and how we can make sure we've got the right facility in the right particular place. But again, thank you very much for today. Appreciate it.
Thank you. It's really helpful.
Thank you, Chair. Thank you, Chair.
Thank you.
Thank you. Thank you.
Okay, I think now we've got Professor Graham Betts, Director of Adult Social Care, who's going to give a presentation and update on the Birmingham Solihull ICS system.
Thank you very much, Chair. So we've got some slides to share with you where Mike Walsh is pulling them up. And this really, as you've said, we're just trying to keep everybody up to date on developments within the ICS and what's happening in West Birmingham. So if we move on to the first slide, thank you, Mike. I'll begin by describing the purpose of the ICS, and you'll be familiar with this. It's about the new statutory partnerships between health and care organisations across a local area, and in our case it's Birmingham and Solihull, obviously. The intention is that every area will be covered by ICS by April next year. It's about giving people the support they need, joined up support across health, local government and other partners, including the third sector and independent providers and so on. I mean, in reality, this is driven by the recognition that the healthcare system has been disjointed for a number of years following the Lansley reforms. And Sir Simon Stevens was always very clear this was about ending the commissioner-provider split within the NHS. And it's an opportunity then to build on that and build that collaboration within the NHS and between the NHS and its partners. So that should address the disjointed care we've seen over the past decade. The other thing I would say just before I move on, and I'll come back to this, is the importance attached to improving the health of a population and reducing inequalities between different groups, and that's a key feature of this. Next slide, please, Mike. And just to summarise that, you can see that the aims are improving population healthcare, addressing inequalities, supporting broader social and economic development, which is, obviously plays well into the role of local government as well, and enhancing productivity and value by improving the collaboration within the system. And if we go on to the next slide, the vision for the BSOL ICS is to help everyone in Birmingham and Solihull to live the healthiest and happiest lives possible, which is the ambition. So if we move on and consider the way in which we're developing place within BSOL, and I think it's important to stress this notion of place is really at the heart of the development of integrated care systems and integrated care partnerships. And I mean, it's because of this, I think, that local government in general and in Birmingham and Solihull, we're keen to support the ICS and the development of the ICS because of its focus on place. It fits well with the aims and motivations of local government, which are all about place and always have been. So it fits well with how local government thinks, acts, believes, and so on and so forth, how it engages with local people. And the idea behind place is to improve outcomes for local citizens, creating thriving places and so on, which, as I've said, fits well with our ambitions to deliver better housing, community safety, leisure, employment, etc., all of those things which support people's health and their achievements of good health and happiness. So that, as I say, it fits very well with that kind of model and approach. And it's seen, and I'll come on later, Peter, to what is place. The importance of this is the benefits that we can envisage will come through for citizens and patients. The people in the BSOL system will have the assets, information and support they need to live a healthy lifestyle. The services at a place level should be more responsive because they respond better to the communities that live in particular places. For professionals, and this is something we've developed in adult social care, by focusing on place and ensuring professionals are, have roots into a place, they do a number of things. One, they get a deeper understanding of the communities they serve, and secondly, they build better relationships at a local level, which do benefit local communities in a place. So the improvements or benefits working in that way for professionals as well. And then the system as a whole is better placed to tackle health inequalities and able to achieve essentially, more value by working together. It's that notion of, the sum is greater than the individual parts, and that's really what we're trying to achieve here. Next slide, please, Mike. And this is what the place looks like. So, I mean, this is, you know, the system as a whole is the ICS, and that's the Birmingham and Solihull Integrated Care Partnership. There are 2 places, Solihull and Birmingham. Beneath that, there are localities, 6 localities, 5 in Birmingham, and Solihull is a locality in its own right. And then beneath that, we work in neighbourhoods, which are the primary care networks. And these are groups of GP practices. Now, in reality, all of those things that you see on this slide, you know, already exist. And what we're trying to do is use these as the building blocks for the system as a whole. So, you know, you look at it either way. You can looking down from the top, you've got the Birmingham and Solihull system, all the way down to neighbourhoods. So looking at it the other way, you can see how it's building up from the neighbourhoods, which, as I say, already exist, through localities and then into the place and then the system. Next slide, please, Mike. There's obviously place-based is a particular focus for us in local government, but so also are areas like strategic commissioning, financial flows and so on. These are part of the work streams that have been set up to take forward the development of the ICS in Birmingham and Solihull. The place group is led by myself and Nick Page, the Chief Exec in Solihull, and we are running a regular series of groups, which we call them Design at Place Group. But essentially, this is our way of building up the systems approach across Birmingham and Solihull to what place looks like, what it will do, what it will deliver, and really it's picking up those points from the earlier slide about what our aims and ambitions are and how we can best deliver them. Next slide, please, Mike. And the work we've been doing so far on the place-based working is really making sure we've got a vision and purpose for Birmingham Place and Birmingham localities. We're working through what does that mean and how will that enhance what we're doing and achieve better outcomes for our citizens. We're also considering the activities and resources that will be delegated to place. Some things clearly, you know, will need to continue to be done at a system level. For example, specialised commissioning for those rare diseases and conditions that affect a small number of people but are very expensive. So that will continue to be done at a system-wide level. Whereas more local things, for example, response to vaccinations and so on, you know, could be done better at a place level where people understand and work better with the local communities. We're also in that group reviewing our governance arrangements and the support that will be necessary to ensure that the very local groups can actually deliver the challenge they've been asked, which is to address inequalities and improve the health of the local population. We're also looking at the role of the Health and Wellbeing Board and how it needs to move forward and change in the new environment of ICS, and in a similar way we will want to look at the role of Scrutiny, which, you know, clearly helps to address the acknowledged democratic deficit in the NHS. And we're obviously designing locality working arrangements. We've got a series of workshops which we're running with partners across the entire system so that we can begin to agree what the working arrangements look like at a local level. Next slide, please, Mike. And so the final slide is really just an update on the position in West Birmingham. And obviously, you know, I mean, Birmingham has always been Birmingham. It didn't change. What did change was that a part of Birmingham, Ladywood and Perry Bar, became part of another STP, which is the predecessor to ICS. That will change. That part of Birmingham will become part of the Birmingham and Solihull system. So that's really good news. It means we can work it hopefully in a more integrated way. But in reality, services like community health service, mental health services, social care services, always were delivered as part of Birmingham and part of, you know, so we've always worked in that way. But it does mean that as a new ICS, we need to ensure that we bring in those services, mainly primary care services, which have been working in a different system over the past few years. We've got a transition group, which is including all stakeholders, GPs and so on, the colleagues from the acute trust, and the NHS regulators, to make sure we move it across. We have to look at financial pathways, clinical pathways, and so on and so forth. And we will need to consider the transfer of staff as well. So all of these things have been looked at to make sure that the transition is seamless. We recognise that the system in the west of Birmingham did work differently, so we want to learn any lessons we can from what they achieved working in that way, in a similar way as we will from the work that's been going on in Solihull. But that's the idea, is to build on the successes over the past few years in terms of how services have developed and worked to achieve outcomes for local populations, so that we build a place-based system which truly does address those challenges of improving the health of the population and addressing inequalities in health. And that's the presentation, Chair. I'm happy to take questions. Thank you.
Okay, thank you very much, Graham. That was a really valuable presentation on what I think could be a really beneficial service for the people of Birmingham. So I've got two hands up. The first one is Councillor Islam. Is that still a legacy hand, or have you actually got a question?
और वो 25 दिसंबर को अल्लाह सुब्हानहू व तआला ने उन्हें जन्म दिया.
I'm not quite sure what's going on here because Councillor Islam's on screen, but he's not speaking. So okay, can we get Councillor Pocock?
Sorry, I would like to. Sorry, Chair, because there was some interruption. So can I speak?
Okay, so we're back with Councillor Islam.
Thank you very much, Chair. Okay, thank you very much for your presentation. I got numbers of there's some question for clarification. First of all, I'd like to support your as page 45, where you mentioned partners will be able to achieve more together than would be possible separate, which is I welcome this the aims of my question. First one is at page 45, homelessness continue to work with families to relieve their homelessness. So because in my ward there are lots of people, homeless people, high-rise flats, and there. So if you can actually explain a little bit about it, so that it will I could digest it. And another one is about modern slavery, which is 9. So if you can explain what kind of modern slavery, so that it will be understandable. Thank you very much. These are the two minor points. If you can explain, thank you.
Okay, thank you, Councillor Islam. I mean, I think one of the things that we recognise about homelessness is that the issue isn't just about a person not having a home, it's everything that led them to that, and then we'll support them to be housed and to maintain their home going forward. And we know that there can be a huge range of factors, often interrelated factors, including substance misuse, mental health, debt, family problems, etc., etc., etc. So there are huge things in there. And that's where I think the notion of the ICS working together in partnership in that way, as you said, you'll get more added value, better working, and so you have got a better chance of supporting that person to get back into a house and to keep their house going forward. So that's really the idea, and I do think, and that also fits well with the approach the council's taken in terms of moving from crisis to prevention, where we're trying to get upstream and intervene earlier. And I think, again, if we're thinking about doing that as a whole system, care and health, we've got a better chance of addressing the challenges and issues that people face in becoming homeless. Forgive me, Councillor Islam, I've now clean forgotten the second point you asked me about, sorry.
Sorry, Chair, can I have another minor question to clarify? According to your slide, it was mentioned 63% staffing cost, but it did not mention 23% and 14% which cost. So this is one of the minor points I need to know, if you don't mind. Thank you.
Yeah. Well, in terms of costs and so on, there's no intention to take costs out of the system. So there's no savings being derived from this. So what's in the system will remain in the system. But I think what we need, you know, if we're being candid, and if it was Solihull sitting here, they would say the same. They just need to make sure that what's being spent in Solihull continues to be spent in Solihull and ditto Birmingham. The challenge we've got, and that's why we updated you on the West, is that there is just a concern because the West was in a different system. We need to make sure that all the resources that were meant to be spent in that area we get, rather than what was actually spent. So, for example, you know how budgets go. We may have been spending or meant to be spending 50 million, but spent 48. We need to make sure that the 50 is transferred rather than the 48. And that way we can ensure that we keep the resources we need. That's how we can keep the resources we need in Birmingham to make sure we have the staff that we need.
Thank you. Thank you. Thank you, Chair.
Okay, pleasure. Councillor Pocock.
Yes, thanks, Chair, and thanks, Graham, for your very enlightening presentation. And two comments. Firstly, on West Birmingham, we wouldn't want to let this opportunity pass without celebrating the achievement in integrating West Birmingham into the Birmingham footprint. And I think it is a long battle. Councillor Tilsley's fought it longer than me, but we have, I think, at last achieved the opportunity to plan local authority services and healthcare services as far as we can on one single integrated footprint. Great achievement. Just reinforcing your comment, Graham, about the resources, I too share a concern about the West Birmingham pound. Again, I'm borrowing from Councillor Tilsley's language here. So could we flag that we would like a further report or an update on that process of migrating the resources into the Birmingham system, the BSOL system, to be reassured that we are getting the fair share of what was originally allocated to the old West Birmingham and Black Country CCG. So I think a further report on that would be helpful. Second issue I wanted to pick up was the little table that you have on the geography of all of this. The system, Birmingham, Solihull, I'm looking at your diagram, the place, Birmingham, 5 localities in Birmingham comprising 2 constituency areas of each, and then we have neighbourhoods. But the neighbourhoods are defined as PCNs. Well, PCNs are not geographical units, they're clusterings of GPs, registered patients, basically. So I think there's an ambiguity here about is a PCN a geographical unit or not. I don't believe we have defined a PCN as having a unique geography. So I'd like to request that we get maybe a map would be good here, with the location of the PCNs, which I guess is the location of the practices involved. Do these map into wards? I'm looking at the numbers here, and 6 PCNs per 2 constituencies gives 3 per constituency, which is probably on average clusters of 2 or 3 electoral wards. I wonder whether in planning the spatial work, and this place after all is essentially a place-based geography model, that in terms of neighbourhoods, we might be better to approximate the PCNs to clusters of wards, or at least to have some kind of alignment, because we as elected members, of course, represent wards, and the electorate turn to their councillors within the geography of a ward. So I think there is an ambiguity that needs further work here. And if we are to follow the guidance, which has come from both the GA and the NHS, which is to build from the bottom up, actually building from the bottom up is what we've done very successfully with the Neighbourhood Network scheme. Of course, I'm a great champion of that. And I think the lesson learned there is that we've got these community assets at local level, to which we can now add NHS asset, But I think it would be good to be able to see the communities laid out, if you like, geographically, that can feed into this based model. So I think further work needed to be done to sort out that clarity, which I think is kind of half-formed, shall we say, at neighbourhood level, and needs to be further tightened up. So any comments on that would be gratefully received.
Okay, thank you. Is that, will I come back in that case, Councillor Brown? Is that okay?
Yes. Yeah.
Yes, so just to pick up those points, firstly, I entirely agree, and I'm grateful that yourself and Councillor Tilsley and Councillor Hamilton all continue to work behind the scenes to put pressure on to have West Birmingham come back into Birmingham, and it was successful. So we are grateful for all the hard work you've all done in making that possible. And I do think, in terms of the funding situation, as you'll have gathered, the fact that I mentioned it will indicate we've got our concerns to make sure that we do receive all the money that we should to deliver healthcare in that part of the city. And we can, I'd be, you know, as one of, if you wish, Chair, we can come back with a financial paper just to show the overview and scrutiny committee what that looks like. So that would be possible in the future, and we can take that away and get a date when we could come back with that, if that's helpful. On the second point that Councillor Pocock made, I mean, I agree that this, you know, in reality, this is not perfect. You know, let's be honest. You know, when we talk about Birmingham and Solihull, they're really, we know exactly what we mean when we talk about Birmingham and Solihull. When we talk about constituencies, we're clear. And you know, that's the localities. Is when we do get down to that very local level, it becomes less than perfect, if I'm absolutely honest. And even we all know from the work we've done, you can even have ward situations where, well, actually, the people on that side of the road aren't in the ward, but they see themselves as part of that community. So I do think that's the bit where it does become less than perfect. But I think we recognise we need to work in a way with our partners, with primary care and so on, to make the thing work. But I'd be happy, and again, Mike would be able to help with this, to bring back maps which show the PCNs are mapped against local neighbourhoods in terms of wards and so on, just to show what it looks like. As I say, it's not perfect, but it's probably a neater fit, because we have had several goes at this even in the time I've been here. So I would hope that it would be possible. Is it okay if Mike comes in, Councillor Brown?
Of course, yeah, of course.
No, thanks, Graham. Yeah, no, just to reinforce that point, we can certainly bring some maps back or circulate those to members of the committee to show that alignment between PCNs, clusters of GPs and localities. And as Graham mentions, there have been quite a number of iterations of this to try and get that alignment as well as it can be, but I think it's always recognising that to some extent that's an exercise in pragmatism and best fit, rather than it being an exact alignment of PCNs against localities or wards is even more challenging, as you mentioned.
Okay, thank you for that feedback. Can I just ask you, Professor Betts, when, in terms of coming back with the financial report, had you got any indication of what timescales you'd be thinking that would be on?
I would have thought that we would be in a position to have that within the next couple of months, because obviously, you know, as you know, we're trying to get all the budgets sorted out, aiming for that April 2022 date. So really, we ought to have it by then. So if we were thinking February, would that be reasonable, Councillor Brown, just to make sure we've got a bit of time given everything else that's going on?
I would have thought so. If I speak to Gail outside this meeting and then liaise with you in terms of what would be a good time for the committee for you to come back.
Yeah, that would be
work out.
Yeah, thank you.
Okay. Does anybody else have a question besides myself? No? Okay then. So firstly, Graham, thank you for the presentation, because I think the ICS could be a real benefit to Birmingham. I just wanted to sort of ask three sort of like sub questions. You're obviously going to be working with 30 PCN groups across Birmingham, as well as dealing with 10 other work streams, as well as the place system. So I'm just wondering how you're going to be able to ensure a local model of place happens in the city as diverse as Birmingham, with the large geographical footprint that Birmingham has. And then secondly, how would you feel you're going to be able to retain a focus on place when you're taking responsibility for NHS resources and performance? And then finally, in terms of support, because I understand you may be supporting effective multi-agency partnerships covering the NHS, local government, voluntary and social enterprises across the area. Is this possibly not a bit of a big ask for any organisation to take on? So thank you, and your comments would be welcome.
Yeah, thank you, Councillor Brown. Let me just glasses. Can you read more and writing? This is a symptom of spending too long working on laptops now. Yeah, I think that's a really good point. That one of the first things we raised, we are colleagues in the NHS, when we began to talk about the model, was the opportunity this had to really focus on the diverse communities within Birmingham, rather than the models we've seen in the past, which kind of very, you know, if I'm in my mind, I would describe them as sort of Western-oriented medical models. And what we argued was this was an opportunity to engage communities and look at health and healthcare, you know, how different communities respond, you know, to health, how they perceive issues in health and so on. And it does give us that opportunity to develop services which really fit with and meet the needs of those diverse communities in Birmingham. So I think this is one of the real strengths of the place model. It gives us a better opportunity to do that than the current models we've had, because the SDP, for example, was very much a top-down enterprise. So I think there is, you know, there is more opportunity there, but that really does take us on to the second and third questions, which really, I mean, it would be a big ask at any time, you know, to make these kind of changes, because they are quite fundamental for the NHS in particular. But to do it at the same time as we're battling this pandemic, you know, is going to be incredibly challenging. So I think you're right to say that, and there is a risk that what that means is that we, instead of developing it in a way that it ought to be, we kind of just do as much as we can given all the other pressures in the system. So I do accept that. I think what we are trying to do, though, is to engage partners and colleagues throughout the system, so that you know, the ask we're making isn't just of a few people or a few, you know, one or two organisations. It's of that broader partnership across Birmingham and Solihull, and in that way, I think we can mitigate some of the risks in not having enough capacity in the system to develop things effectively. The other thing I would say is that we have challenged colleagues in the NHS on this, particularly about performance measures, and you know, and how, you know, what we develop as performance measures across the system. I think they do need to change what they measure and how they measure it. And I think we are making progress here. So, for example, when we've talked about inequalities, there is a recognition that there are inequalities in the system, and for example, in who gets to the top of the waiting list first and those sorts of things. And I think colleagues in the acute sector have recognised that the system is inequitable at the moment. There's some groups know how to manage the system, work the system better, and they can't allow this just to continue. They need to address it, and they need to work with diverse communities to make sure that we don't perpetuate those inequalities. So, in answer to the second and third question, I think the NHS is more aware now of the challenges they face. They need to respond to them, and they need to measure how they respond to them differently than they have in the past. And there is a recognition we will have to utilise the resources within the system, including third sector groups and so on, more than we have in the past if we're going to make the progress and, as you say, achieve the opportunity that the ICS presents. So I hope that goes some way to answering the question, Councillor Brown.
Okay, thank you for that. Does anybody else have any questions? I don't see any hands raised, so I'm assuming the answer to that question is no. Can I thank you, Graham and Mike, for your presentation today? I think it's been really useful and really valuable, and I'll liaise with Gail regarding the possibility of coming back to the committee in the early part of next year. So thank you both very much for today.
Thank you very much.
Okay, I think the next item we got here is Birmingham Safeguarding Adult Board Annual Report 2020 to 2021 and the strategic plan for 21 to 24. And we have Sherry Dale, who's the independent chair of the Birmingham Safeguarding Adult Board, and Asif Mansour, who's the business manager for the same board as well. So Sherry and Asif, over to yourselves.
Thank you, Councillor Brown, and thank you, everybody. Good morning. It's really good to be with you again today. I'm just really sorry I'm not sitting around a table with you somewhere in Birmingham, but sadly it's not to be the case for a little while longer. So we'll go through our assurance report first of all, and then take you through our strategic report second, if that's okay. I know that you'll all have read the assurance report, and I'd really like to take you through some of the highlights. As you know, our main aim as a board is that people with care and support needs in Birmingham can live free from harm, free from abuse, and free from neglect. And to achieve this, just need to remember there's only 3 of us on the board, 4 when we're fully staffed. So we really absolutely rely on all of our partner agencies. And they come from all sectors, from the statutory sector, and that's a given, but also from the voluntary sector, from the faith sector, from carers, from citizens themselves, from the charitable sector. So we're very grateful to all of those. So following on from what's been an incredibly difficult year, if we can just start with taking you to page 3. And we just felt we needed to highlight all of the extra work, and these really are just a few of the extra assurance and general activity that were undertaken by the safeguarding community and by the board itself during that year of 2020-2021. So you'll see on there that we immediately upped our quarterly meetings to 4 weekly meetings to make sure that safeguarding adults with care and support needs stayed top of everybody's agenda. We also created an operational safeguarding leads forum that met fortnightly. And basically that meeting was to troubleshoot any issues, and sometimes met weekly if need be. And it was so successful that the leads themselves have continued that on during this last 12 months. You'll see that we put together easy read leaflets for volunteers. There was an e-learning framework available immediately. We also put easy read leaflets in there for citizens, so people knew what to do and where to go to seek help. And during that first year of the pandemic, we increased our assurance 4-fold on behalf of adults with learning disabilities in particular, on victims of domestic abuse, on unregulated accommodation, but also for people who slept rough on our streets. So it was increasingly important to us to have that regular connection with people. If I can just now take you on to page 5 and just remind you of our purpose and our vision. So you'll see on there our general purpose, and for that our main focus is on 3 key drivers: to make safeguarding personal, which is keep the person at the centre of all that we do, that they're in as much control of their lives as they possibly can be whilst remaining safe. That safeguarding is everyone's business and it doesn't become a specialist service as it was when we first took over 5 years ago. We've worked really hard as a community in safeguarding and as a board to make sure that safeguarding is every single person's business from floor to board of every organisation, including the citizens. And then finally, risk enablement. And by risk enablement, it's encouraging people to make their own decisions and to understand the risk within those decisions and not to wrap people up so tightly in bubble wrap and cotton wool that we ruin their lives, that they're almost afraid to go out of their own front door. And it is a balancing job for all of our city workers, but it's one that they take on with gusto. And you'll see that we've got a statutory duty under the Care Act of 2014. And mostly those three duties, and those of you who've been on this committee for the last 5 years will have heard me say this and moan about it every time. I apologise for moaning again. But actually, the statutory duty we have are threefold. 1, to give you an assurance report. 2, to write a strategy. And 3, to carry out safeguarding adult reviews. And only really the third one makes a huge difference. So I would really like to, and we still campaign nationally, to have more statutory duties that will actually influence people and make a difference to people's lives. So we focus on adults with care and support needs. And to do that, you'll see there people with learning disabilities, mental health needs, dementia disorders, long or short-term illnesses, addictions, people who are elderly or frail due to ill health or disability or mental health illness. And alongside that, they need to have difficulties with looking after themselves. So, for example, not everybody with a mental health issue will come under the Safeguarding Adults Board in terms of the Care Act. Not everybody with short-term illnesses will come under Safeguarding Adults Board's work. It's those that really need help and support to look after themselves, to keep them free from harm, abuse and neglect. If I can now encourage you to have a look at page 7, you'll see our governance model. And this is how we work, basically. You'll see on here how we model ourselves, how we assure ourselves, how we deliver what we say we're going to deliver, that you'll hear about in the assurance report right now, but you'll also see in our strategic plan coming up later on. So you see that we have our Safeguarding Adults Board. We work very, very closely with the 3 other cross-city boards, the Children's Partnership, the Community Safety Partnership and the Health and Wellbeing Board. We have worked very hard to create strong links across and create a Safeguarding Adult Partnership now of over 160 different organisations within the city, including citizens themselves and carers groups, to the left of your screen. And then you'll see we've got a delivery group who meet quarterly and monitor what we're doing. And underneath that, we have our subgroups. You'll see we have a Safeguarding Operational Leads group I've mentioned, our Learning and Development group, our SARS group, Quality and Performance subgroup who keep us on track, and our Task and Finish group, which is based on need only. And all of that makes sure that we deliver on our strategic plan. Thank you, Ash. If I can now point you towards pages 9 to 11, where you'll see for this year, 2020-2021, was the final year of our last strategy. And those were our 4 strategic priorities during that strategy. Priority 1 on communications and involvement. Priority 2, prevention and early intervention. 3, empowerment and enablement. And 4, learning through development and assurance. So the following page, page 10, you'll see what we did. So I like the old school. We said what we said we'd do and what we did, because I just think it creates a really tidy line to show people what we've actually achieved. So you'll see just some of the highlights there on priority 1 that we can fit into this assurance report. But we created, through our business manager who took the lead on all of this, the safeguarding workbook, updated our website. we made sure that all of our communications were accessible more than ever during this year. So we have our business manager to thank for that, and Ash is on the meeting right now. We also, in priority 2, we did an awful lot of work of continuing to seek assurance on the work on unregulated accommodation, because we feel that that dark corner hasn't gone away yet. We're very, very grateful for all the work that's going on in this arena, but we know that it continues to be a huge risk for us here in Birmingham, but also elsewhere in the country. And it's one that's now being championed nationally as well as locally. And equally, we're very grateful for that. So we feel our role is to seek assurance on that work and to make sure that that continues. And you'll also see there that we've worked very closely with trading standards to highlight scams, particularly whilst everybody was being stuck at home, working from computers or from telephones. We're at risk of people just knocking on the door with scams. And we focused on seeking assurance for adults with learning disabilities and adults who may suffer from domestic abuse in particular. On priority 3, we promoted our events online immediately, particularly making safeguarding personal during that year and making sure that everybody as an individual was at the centre of whatever was happening. We promoted strongly the use of the waiting room directory, which is constantly updated and incredibly accessible for citizens and our partner agencies. And we also created our multi-agency competency framework to make sure that everybody had some kind of regulations around the work that they were doing. And we continue to develop and share our learning from SARS and the recommendations around those reports. And then finally, on priority 4, some of the highlights around there was that competency framework I've mentioned, but also we worked very hard on finalising our SARS reviews that were left over from the previous year and were held up because of COVID. And we sought assurance on a number of key areas that you'll see later on during this assurance report. And just for noting on page 12 and 14, some of the amazing work of our key partners. They were determined this year to make sure that safeguarding continued to be a priority for them. And you'll see on between page 12 and 14 the work that they were dedicated to during that period. So again, we're very grateful to those partners. If I can take you to page 18, and our SARS, as I've mentioned, Safeguarding Adult Reviews, is one of our 3 statutory duties, is to carry out those Safeguarding Adult Reviews. And you'll see the criteria there, and it's very tight in the Care Act. And often people get confused, but it's very clear in that Act that there has to be reasonable concern that BSAB, its partner agencies, and that's multiple partners, have not worked together to safeguard people, to keep people safe from harm, abuse and neglect. That the adult in question either died or had abuse, serious abuse and neglect from their experiences. So during that year, we had 6 referrals, and none of these referrals met the criteria for the review. However, we did complete 3 reviews during that year that had been started in the previous year. We also, during that year, shared our learning from reviews, from previous reviews, that is, and our recommendations. And we continued to follow up on all of those recommendations, to monitor them closely through the work of our SAR panel, and to monitor progress on those recommendations. And that continues to date. And if I can take you over to page 19 now, and our assurance model. And you'll see our assurance overview here. You'll see that we work very closely with our partners. We ask for annual statements. And this year we've done something very different in 21 going into 22. We've actually added in challenge events that I'll talk to you about next time. Our citizens' voice. So we ask our citizens about their experiences of safeguarding, whether they were made to feel safer afterwards and after their connections and contacts. We ask for various reports to come to our executive board and through our quality and safety board, and we use data and intelligence management. So from the data that we collect, we work on what that's going to tell us and follow up on what that tells us and ask for further assurance on that evidence. So Ash, if I can move on a page now. So you'll see on here some of the assurance that we sought during that year and what that assurance told us. So you see that we sought extra assurance during that first year of the pandemic. In particular, we requested assurance on rough sleeping, on care homes, on support for adults with learning disabilities, on the leader reports and evidence and what that has told us and the follow-up to that. We saw extra assurance on safer discharges during this year because we were very conscious that often people were going back to homes where they may be alone during this COVID year. We sought assurance on transitions to adulthood, on the new service there, which is a tremendous service. And again, just to remind you, we sought continued and additional assurance on unregulated accommodation during this year. And on the right-hand side, you'll see some of the things, and not all, because this is the highlights of in the assurance report of the areas that we'd learned about. So we learnt the additional steps that were taken to ensure safe discharge from hospitals, for example. We were informed that there were no blanket DNAs being applied in Birmingham. We were assured that the leader review action plan was being continued. We had extra assurance that learning from Winterbourne, for example, was still being rolled out and that we were still working on those outputs and progressing those recommendations. And we were assured, in particular, during that first year of COVID, that our most vulnerable citizens with care and support needs were being contacted regularly, even though it was remotely, but also that Graham in particular had put in place a system of phone calls, which we were very grateful to hear about, to the most vulnerable people in the city. And if I can now take you on to page 26 and 28, you will see our data that we collect and we hear about. This data is collected from Birmingham City Council safeguarding team referrals, so the section 42 adult concerns data. And you'll see here there was a slight dip in referrals during 2021, which the board was concerned about and asked adult social care safeguarding team to go away and investigate. And they did. They investigated thoroughly and they came back and they could find no real reason other than the focus shifting during that year onto work around the pandemic for all organisations for a short period of time. In that early quarter, that caused a slight dip. So now we see the referrals are back up to where they should be later on during that year and this year in particular. You'll also see from that data in Appendix 3 that the top reasons for referrals remain the same, remain neglect, financial abuse and physical abuse. And equally, you'll see that where the abuse happens remains in the person's own home by people that they already know. So that could be by family member, by a friend, by a carer, a neighbour, but it's somebody that they already know. So this really supports our view as a board that we need to focus our energy on safeguarding awareness in the community. Our safeguarding awareness amongst citizens, amongst community groups, amongst faith groups and volunteer groups, for example, and neighbourhood groups, to make sure that everybody is aware and making safeguarding is personal is everybody's business. So finally, just to say, really, in relation to our annual report, and we hope you accept our annual report and accept the hard work that has gone into it, particularly in this year. We continue to seek assurance in as many innovative ways as we can. And in this year as well, with the pandemic and as even more innovation, you'll hear about that next time we come. But for people with care and support needs in Birmingham, we continue to prioritise safeguarding in the community. And really, on behalf of the board and all of its partners, I'd just like to take the opportunity to thank all of those agencies and the BSAB team, because they are few in number, for the dedication and commitment to safeguarding adults in Birmingham. Because without that, we really wouldn't be able to continue to make all of these improvements possible in what has been the most difficult of circumstances during this pandemic. Thank you. I'll leave you to any questions.
Okay, thank you, Cherry, for that was a really valuable report, and I'm assuming in a short while the committee will feel able to accept that. Is there any members who've actually got a question to ask? I can't see any hands up at the moment. I assume we've got a hand up, Councillor Pocock.
Yeah, thanks, Chair. Just a quick one. Thanks, Cherry, for your report, as always, really insightful. We're looking ahead into a very uncertain period, and obviously the pressures that go along with continued COVID restrictions add to the pressures that create problems. What's your prospect as you look ahead? We're heading to an even more difficult period, do you think, as pressures build up, or have we got the situation under control?
For safeguarding, we had our board meeting on Tuesday last week, and we had the winter plans. We had assurance on that. We had assurance from care homes, assurance from health and social care around all of the work they're doing going into this next period. Hand on heart, I can't say for certain that we've got everything sorted as much as we can, but what I can say is with what we know right now, the teams out there are as far ahead in their planning and assumptions as they can be. Unfortunately, we don't know what we don't know. So there's some things that will pop up, but I sincerely believe and felt assured at the board last week we're in a far better place than we were at the beginning of the pandemic. And the reason being, the partnerships are much greater, the information sharing is much greater, the responses because of that are much greater. I liken it to my old netball days when the coach used to shout at me all the time, get on your toes, Cherry. It feels like all the organisations in the city are on their toes. We're ready, we have a plan. We are concerned as a board, and that was shared last week with the parties, with all the organisations, statutory parties that were there and third sector, particularly around people who are isolated. But that does seem to be taken into consideration into everybody's plans. And I know there are weekly meetings, sometimes daily calls around some of those very, very vulnerable people. But I would still urge everybody to be absolutely conscious of safeguarding those people who are isolated, because that's where we started to find in the first year things unravel a little bit around, for example, some of the discharges for adults with learning disabilities who are going back into their own homes or back into unregulated accommodation. That's just one example. And I know this time we're very much more aware of that. So I am very hopeful, but those are the people that we really need to keep an eye on.
Okay, thank you for that. If nobody else has got a question, I've got one myself. This is a little outside your team's remit, I suspect, but I'd be interested in your observation. I was looking at some research by the National Fraud Intelligence Bureau, which found that the people most at risk of fraud were older people who had mental capacity, who therefore didn't need any formal care and support plan, especially those people living alone. And my question to you would be, what advice can you give in terms of how are we able to support them at a time when, due to COVID, they may be even more isolated than they were or would be ordinarily? So your comments would be welcome.
Yes, thank you, Councillor Brown. It's a really difficult one, isn't it? Because in terms of the statutory nature, they don't meet that level 4 care and support, so they won't have that connection. So really, my view, and I do some other work outside of this job with third sector organisations and through food banks and with the Trussell Trust. And the work that we're doing there is through community connections, because the only way we can help the group of people that you're talking about is if they're connected to somebody else, somebody that can say, look, Fred, or look, Sue, this really doesn't sound right. This really isn't a good idea. Somebody they can check in with, somebody they trust, even if it's by telephone and they have a weekly telephone with somebody. So we can influence in terms of making sure we get information through their door. We can make people aware, and Trading Standards do a tremendous job in sending out messages, in leaflets, in websites and in emails, but it doesn't always reach some of those people who are very, very isolated. So through my other work, the only way we found to make sure they're aware and it doesn't happen is through working really hard to connect them to community groups, to third sector groups, to luncheon groups, to volunteers who may be able to give them a phone call every few days or at the very minimum once a week. So that would be my advice, really. And I do think we need to work to connect all of that up and to have that advice freely available when people come forward. And I know it's often said that there's no wrong door, and I really believe that. So if they come to us and we can't provide a service, we should be able to connect them to other people who can support them and can help them with that advice.
Okay, thank you for that, Chair. That's some really useful comments there, I think, for all of us on the committee to be looking to take forward, both as a committee, but also in terms of our own individual wards. So on the committee's behalf, thank you for coming and thank you for your presentation, which I'm sure we would be happy to accept.
Thank you, Councillor Brown. Thank you.
Thank you.
Would you like me to just quickly take you through our new strategic plan?
Of course, yeah.
Thank you. Okay. So this strategic plan covers the next 3 years from 2021 to 2024. And this year we've worked particularly hard, as I promised to you last year when I came and I talked about our assurance that we would increasingly year on year get better at collaboration and co-production. So this year we totally focused on those two arenas, and unfortunately it was all done through virtual means, but we still managed to do it. So we really worked hard through our safeguarding operational leads. We went to primary care meetings and met with GPs. We met through citizens groups. We met groups through MenCap and people with hearing difficulties, physical difficulties. We met with carers, the faith sector, the third sector, a range of statutory groups. So we worked very hard to make sure that this plan, everybody recognises their words in it. And I'm really happy to say that when we went back and checked that with them, they did. So I'm very happy to present this to you for the next 3-year plan. So whilst I'm going to take you through the plan on a page, when you do read the full strategy, if I could just push you to have a look at page 4, which is the aims of adult safeguarding, page 7, the key principles, and page 10, which gives you more detail on the purpose again. Obviously, you know, in your own time, but that would just give me great pleasure for you to know that about our board. So here you'll see our plan on the page, and it highlights the key actions that we're going to take under each priority. These will be monitored and measured through our quarterly structure of meetings on our quality and performance groups and our governance structures, and they then inform the board at all of our board meetings on our progress. And we also do an annual check, because this is a 3-year plan, and sometimes, you know, you need to know when to stop flogging the horse. So if we're going in the wrong direction, or something is completed, or we've got something wrong, then we do say, and we do have the courage to say, no, that's wrong, or this is the wrong direction, and we will change it on an annual basis. So our 4 key priorities there, Ash, if you can just come down a little bit, thank you. You'll see the 4 priorities that were decided through that co-production and collaboration. Everybody decided that we need to keep communication involvement because it's such a strategic and critical area. We've kept prevention and early intervention. We made making and safeguarding personal and learning through development and assurance. And then just beneath that, some of those key actions on what we will do under each of those 4 strategic priorities. So just to point 1 or 2 out on there, it came up through our work collaborating with carers that carer stress was huge, and raising awareness of carer stress and the pathways for carers to refer for their carers assessment was critical. Because it also came up through one of our Safeguarding Adults reviews that we've carried out, that actually the impact on carers was often misunderstood and not highlighted by everyone. I'm not saying always, but often we're finding that this is the case. So this is an action for the board to make sure we raise awareness of safeguarding issues for carers alongside people with care and support needs. We're also going to continue to engage because we've been asked, the feedback from the collaboration we carried out was really, really positive, and people want to still be involved. So we promise to keep doing that. We're going to seek assurance that vulnerable adults, young adults, transition safely into adult services, and we're going to increase that work. And then under priority 2, you'll see there, we're going to develop and implement a new self-neglect protocol. And I have to say, we've already started work on that, and I'm really pleased because this strategic plan was completed in September. So we launched our self-neglect protocol a couple of weeks ago. We're going to continue to seek that assurance on exempt accommodation because, as I've said, we feel that still is incredibly important. We'll continue to share that information for prevention, particularly around abuse and neglect for people who are suffering from loneliness and isolation. And some highlights of actions from priority 3 there. We'll carry out our assurance of process for missing adults with care and support needs. We'll continue to seek assurance on progress with the Poor Relations report with West Midlands Police. We'll continue to develop our Safeguarding Adults dashboard, and that came to our board last week too. And we'll continue the work on that to make sure that we focus also on people's experience of safeguarding and not just on the numbers. And then finally, in that priority 4 there, you'll see that we are furthering our work around the leader action plans, furthering our work on sharing learning, and we've held some recent events again with our wider partnership. We've had 110 organisations on a partnership event just recently around some of our Safeguarding Adults reviews. And the feedback to that has been really positive about people's learning and the areas that they're going to change. And then we've developed a yearly learning plan. And this year we're going to seek assurance on that workforce competency framework that I mentioned we've just put in place in our assurance plan. So you'll see that from our work, the strategic plan is comprehensive, and really this plan on a page is to share with all of our partners. And so you've got a strategic plan if people want to read that in depth, and the plan on the page for the highlights. But the next 3 years, I think, is going to really focus on people with care and support needs, on the people on the margins of the work that we do. And also, Councillor Brown, is the ones that you've just mentioned, the people that just miss out. And at the board, we agreed that we're going to do a deep dive into some of those areas, particularly those people that don't quite meet the criteria for support. What happens to them? What happens to their safeguarding? What happens to their life? Where do they go? And work out what we need to do next. But I'm sure that you know that this board is not afraid to go into dark corners, and I see that as our job. I think our job is to look at the dark corners, to agitate, to find out what needs to do, to bring people into the room and ask those hard questions about what's going to happen next. And I hope you feel confident that that's what this board does, and that's what we will continue to do. And just again, to say at the end of this, a thank you to all of those partners that make sure that this strategic plan is carried out. Because we've worked really hard to build that strong relationship in the Birmingham. When we first started in safeguarding, when I first started as chair 5 years ago, we worked hard to bring all those wider partners to the table to make sure that safeguarding is everybody's business. And I think we've achieved that, and that number is growing on a daily basis. And we have so many people talking about safeguarding now that we didn't have before. So again, thank you to everybody, and thank you to this committee, because I know that you have thoroughly supported safeguarding adults over the years that I've been here, and I'm always grateful for that support. Thank you.
Okay, thank you. Before you go,
sure.
Can I just ask a couple? Well, one's a comment. I'm really pleased about the emphasis you're going to place on the impact of carers going forward, because I think carers is an issue that's really close to my heart in the same way as it is, I know, to a number of other people on the committee. And secondly, could you give a bit of an overview in terms of how big a role social media will play in your communication strategy going forward over the next 3 or 4 years?
Yes.
Thank you.
Yes, I mean, if you'd have asked me a couple of years ago that, or said to me, you're doing everything online, Cherry, I think I'd have fallen off my chair, because I'm the biggest technophobe you'll probably ever meet. But I think social media is going to have to play an increasing role in what we do. I would really like us to get back to face-to-face sooner rather than later as a priority. Because I think it makes a difference to sit in with people, with citizens in particular, in a room, so they can see us and we can build that relationship. But we will make sure our website is increasingly up to date, and we've just commissioned some changes to it so people can change the colouring, because some of the feedback from that collaboration that I mentioned is apparently if you have to pay for it, but you can make amendments to your website so people can change the colours on it so they can view it better if they have difficulties in that. We're looking at audio more now for people who find both aspects difficult. We have regular newsletters that go out through social media. We obviously use Twitter a great deal. So yes, I think it will play a key role. But I'd like to be able to get back out and see people face to face. We're still doing everything virtually. We're not frightened of doing that. And I mentioned we had 110 different organisations on a virtual Safeguard Adults partnership for 4 hours a few weeks ago, and that worked really well. So we're pretty good at it. It's not my favoured choice, but we're pretty good at it, and I understand the need for it.
Okay, thank you very much for that, Cherry. All I would say is, if you think you're a technophobe, you've not met me, because I really don't like it. And I think you gain much more of a connection with people if you're speaking to them face to face, certainly if it's in a professional capacity. So thank you for your report, and thank you for your time. Appreciate it.
Thank you very much. Thank you. Bye-bye. Bye-bye. Thank you. Bye-bye.
Thanks. Right, we've now got Maria Gavin, who's going to present on the annual social care performance monitoring for quarter 2. So it's over to yourself, Maria.
Thank you very much. So colleagues, members, you'll be aware this is the quarterly update on the adult social care performance measures. And in your pack, the performance measures start at page 82. The way we've laid them out now, following discussion with yourselves in Scrutiny, is we've picked out the red measures first, followed by the measures we regularly report on, some of which are also red, so you'll see them twice. And then there's the set of all the indicators, the scores, and the commentary that sits alongside those. So I was going to run through the red measures first, followed by the usual ones that we report on that aren't red, and then lay it open to further questions if you would find that helpful. Can I check, would you like me to try and screen share the measures, or is that something, Gail, that you can support with?
Hi Maria, I'll get it up for you.
Thanks very much.
Okay, thank you for that, Gail. Appreciate that.
So if I start running through the measures first, at the request of Scrutiny, we now start the report with the red measures. So the first red measure that you'll see listed on the Scrutiny report relates to, let me just check I'm on the very first one, relates to clients reviewed in the last 12 months. Members of Scrutiny might know that we've been putting a lot of focus and work plans in place to increase the number of people who get their annual social care review. Our performance here at the time of this report in September was continuing to improve both between August and September when the report was done, and also for the quarter. So we were making positive moves in terms of improving the number of people who've had reviews in line with the plan, but we're still short of the target we set ourselves for the year. Hence, the report is still being shown as red. The second measure we're reporting on is shared lives. Now, shared lives, again, you know, we've got quite an ambitious target there of having 140 shared lives placements by the end of April. At the moment, we're at 103. And again, members of Scrutiny might be familiar that this number goes up and down unavoidably as citizens leave shared lives placements, often for very positive reasons, to go into more independent living, or unfortunately sometimes because their needs are now beyond those that can be met in a private person's home. So our number drops slightly. It's 103 as of September. We're still continuing to have a large focus in the Cared Lives service on recruiting new carers. Again, still slightly more difficult with some of the COVID restrictions that were in place up until the start of the summer. But we're working very hard still to support our existing carers as well as recruit new carers. But Shared Lives remains red because we're not on target to get 140 people by April. The next measure, which is rated red, relates to the new measures in around our transition service. And we've been reviewing how we report this really for next year's report, because transitions, you might remember, we had a pilot running around preparation for adulthood. And at the moment, we report on both the number of young people who are being supported, as well as the proportion that said they were satisfied. Now, because the preparation for adulthood was initially a pilot working with a set group of young people, the number of young people we're working with has decreased over the year as some of them have become settled and moved out of needing support from the programme. So at Q2, the number of people being supported had reduced. That was actually quite a good thing, because it means that those young people have now got settled plans and clear arrangements in place. The proportion who said they were satisfied, you'll see in the script, is at 91.2%. So we were very positive about the impact of that support on young people. But whilst we were still in pilot mode, awaiting for Cabinet approval for longer term funding for the service, the number of young people supported naturally reduced. Similarly to the next measure around the number of young people who feel they can achieve their outcomes. Again, you'll see the number dropped from Q1, but the actual satisfaction with the service remains really high at over 90%. And again, the number dropped because the overall population being supported reduced whilst it was a pilot. They weren't able to take on new people. So cases have been presented to Cabinet around preparation for adulthood and the wider support for young people, as I mentioned, to make these services a substantive part of the adult and children's social care offer going forward. So we're looking forward to hopefully some equally high levels of outcomes and positive feedback above 90% for both measures, and being in a position to start to support more young people as we move into the substantial services. Can I check, is it helpful to pause there, or whether you'd like me to move on through the regular measures?
I think Councillor Pocock's got his hand up for a question. So do you want to take your question now, Councillor Pocock?
Yes, thanks, Chair. That's great. Appreciate your comments on the preparation for adulthood, Maria. That indicator on numbers is a tricky one. The performance level, 90%, is good.
Yeah.
Numbers is not really a kind of fair indicator of the volume of your work. So I don't know whether you've got some thoughts about a better indicator. I'm thinking here, can we measure the proportion of young people who could engage with you who are actually engaged with you? We've talked about that some are dropping out, so that might be a kind of uptake indicator. Or should we hang in there, and obviously as the work becomes mainstreamed, and I hope we're suited for this, then these numbers will start going up. There again, it's difficult to know whether your numbers are meeting target or not if there's no target for numbers to shoot at. So your comments of interest. I'd be quite happy if we pause on the numbers indicator at the moment, because I'm not sure it measures anything. But if you've got a better indicator, I'd be pleased to hear it.
Yeah, I think John Williams and Caroline Naven, who run the service, came to give Scrutiny an update quite recently on PFA as well. So we've re-looked at this measure for next year. What we're proposing to do for next year is do the percentage measure in terms of the number of young people we've supported whose outcomes were met. We will include the physical number in the narrative, as we know it's helpful for elected members to know the actual number of young people we're supporting and the number of families going through transition. But we're moving to the percentage measure. With regards to baseline, because it's a new service, we don't have an established baseline or target. So I think once the new service mobilises and we start to get a couple of years of data, we'll be in a better position to set an ambitious target around it. So for next year, we're proposing to focus on the percentage measure, but keep the figures in the narrative so members can see the actual numbers of young people being supported.
Yeah, I'm happy with that, Chair. Thanks.
Thank you.
Thank you. Councillor Fowler.
Thank you, Chair. I haven't had the time to look further down on the papers that I received. Apologies for that. What I'm just wondering again, and I'm seeing it's not just on this one specifically. It's just that I see what happened, what we're doing, but I think, like Councillor Pocock, a bit further is we're talking about measurement, but I still have been asking about putting outcomes on these things. Because what happened and what we're doing is great, what's happened and what you're doing, but it's the outcomes and how it's been measured that I know that me and Rob want to see so much, and that is still not happening unless it's further down in the report. So if it is, apologies for that.
If I might reply, Councillor Fowler, thank you. The percentage of people satisfied is part of the key outcomes for the preparation for adulthood service. So if young people are satisfied, that really is part of that key indicator that we're proposing to measure going forward. It is referenced here as part of the text, but we are reviewing how we present it as a more helpful measure from next year.
Thank you. When I said at the beginning that it wasn't specifically on this that we've got on the screen now, it's on all others as well. I'd like to see how it's been measured and what the outcomes of for all members, and particularly for those people that may be listening and watching, residents and others. Thank you.
Yeah. We're always happy to keep the measures under review, Councillor Fowler, and as a directorate, I think you'll know that our vision is very much based on achieving better outcomes for all the adults and young people that we work with in the city. So where we can, we do try and incorporate outcome measures as a key component. I think a lot of the measures we're required to report on nationally are numerical as well, though. So collecting some of that more numerical rate, like the number of people admitted to long-term care per 100,000, are areas we still have to report on, and do tell us quite important information often about whether we're achieving ambitions of having people supported at home. But we really support your position around it's the difference our support makes to people in the city, which is what we really aspire to measure. So where we can, we increasingly are looking at those outcome measures, but we do accept that we're often driven by monitoring that also requires us to collect some of that numerical data.
I mean, just finally, Chair, and then through you, it's one thing that I often go on is, yes, what has happened, what we're doing, but people are working on different things. And again, it's not just on this, it could be on any RAG reports that come through from any committee. People like to see what difference has this made, and that is where we get the outcomes. And I still don't see on any reports that we've got through, we see what's happened, what we're doing. I want to see, as I'm sure others want to see, is the outcomes, what difference it made to our citizens. Thank you, Chair.
Can I ask you, Councillor Fowler, would you be thinking possibly of some anonymised examples potentially in terms of outcomes? Would that help if a couple of those were presented?
Yeah, we could try that. I see Rob's going to come in, so maybe because I know that Rob feels the same. I feel it's just really helpful for what's happened, the reason why it's fell or whatever it's done. This is what we are doing, and then you come back and say, right, this is what we've done, and this has been the result, i.e. the outcomes. This has been the result of what we've been doing. And as I reiterate, it's not specifically on this RAG rating that's on the screen now, but it's on all, because as I said before, a long time ago, and I'm sorry if I go on to Warwickshire County Council, but I do recall that was one of the comments that I made on performance indicators, and it didn't happen there, and then it actually did. They first of all, they then concentrated on the reds, but then they actually did and actually added, here are the outcomes. So we all knew what difference it made for the council, but specifically for actually the people that work in a particular sector, but also the difference it made to our residents.
Okay, thank you for that, Councillor Fowler. Would that be something possibly, Maria, we could actually look at potentially for going forward?
Work further with members and scrutiny on how we could get that richer picture. Very happy to do that.
Yeah, okay, thank you. Do you want to carry on? Because I don't see any more questions. So do you want to carry on with your presentation?
I think Councillor Pocock's hand might be up.
His face, yes, he's there. He's just appeared on my screen. So yeah, well, he's disappeared again. His hand has anyway. His face has arrived. So Councillor Pocock.
Yeah, thanks, Chair. Sorry, the technology may not be brilliant. Just a quickie, and hoping not to divert us too far from the agenda. I think Councillor Fowler raises an interesting question. I agree with him that we should be working to outcome-based performance management and not process-based performance management. That principle, absolutely. the outcomes are longer term, I suspect, over 5 or 10 years. Young people who've gone through preparation for adulthood will not have the difficulties that young people who didn't go through it have had. And I think what might be helpful here for us is, in the business case for preparation for adulthood, there is a presumption that if we do this, people will be better as a result. So it might be good to kind of restate, if you like, what life was like without it and what life ought to be like with it after, let's say, 5 years into adulthood. So what benefits are we trying to achieve over that period of time? And then over time, we can start to put in place some measures to see whether or not we actually have achieved those benefits compared to a baseline of pre-preparation for adulthood management, when obviously certain kinds of problems have occurred. So if you get the point I'm getting to, an illustration by virtue of the business case anyway, then some forethought as to how we track this. But I believe it will be 3-5. It's kind of a generational thing, really. So I guess it's a bit early to start measuring the absolute outcomes so early in the cycle, because I think it stops problems that would have occurred several years as you move into adulthood rather than like tomorrow. But your thoughts on that would be appreciated.
And again, for you, very quickly, Chair, I think Rob is absolutely spot on there, because there are short, medium and long term outcomes. So yes, I hope that's been helpful to Maria, because it'll certainly be helpful to us. Yes, and I certainly echo that. Yes, you're going to have short, medium and long term, but obviously where the short terms and mediums, that's obviously very helpful on performance management. Thank you.
Thank you both, Councillors Pocock and Fellow, for those interventions. Do you want to carry on, Maria?
Thank you. So Gail, if we could scroll down, I think the next measure is the rate of admissions into care homes. So we're now on to the regular sort of top 5 measures that we report to Scrutiny. So some of these will include direct payments and shared lives, and shared lives we've already run through. So in terms of long-term admissions to residential and nursing care, our aim here is to always keep reducing that number. Scrutiny members might recall that during the pandemic, we had a rise in admissions, which was against our trend of downward admissions into care homes. As I said, we're very keen not to admit people into care homes unless that's their desire and they really need residential or nursing care full time, because we know most older adults we work with prefer to live at home. So less admissions is a positive thing. So I reported last quarter that we'd started to see a recovery. Our trend of increasing admissions into care homes, which happened during COVID, was correcting itself and the level was dropping. And we've continued to reduce this quarter, which, as we say, is a positive move in the right direction. We really work hard with health colleagues and with our social workers and OTs to promote home first as the main option for support. So we're making good progress and ahead of target on that particular measure. Thanks, Gail. Clients reviewed in the last 12 months, we've run through as part of the red measures. If we could scroll down, thanks, Gail. Direct payments. Again, members might recall that during COVID, we saw a plateauing of direct payments offers. And this measure from September, we're still experiencing that kind of trend. We'd held a really high number of people on direct payments. We're top quartile nationally on direct payments. So we have really, really strong performance against this indicator. And we held that during the September period. So it hadn't changed very much. And we're still aiming to try and hit that target of 39%. We're at 38.2 over the next few months. We may, of course, be impacted again by the pandemic, but at the moment we're still working very hard across health and social care to promote direct payments, to really encourage people to take control of their own care and support needs, so they have maximum flexibility and choice around how that's designed to meet their own individual lifestyle and requirements. So we've held our own on this, but we are a very, very high performer on this measure anyway. Shared lives, we've already discussed. And the last measure, early intervention, is still not yet being reported nationally as a substantive measure, but we are looking on our corporate measures last year to move towards the new measures nationally that are taking place around the pathways that people go into upon discharge from hospital. So how many people go home, how many people go into short-term care, how many people go into long-term care. And there are national targets around that the system is gearing up to look at how we do that collective measures. I can see Councillor Pocock.
No, sorry.
That's the end of the top measures. Again, is it helpful to pause there for comments and questions?
Yeah, Councillor Pocock.
Thanks, Chair. Yes, just a very brief one, Maria. The early intervention stroke delayed transfers measure, can you just remind us again when we're likely to get some metrics here? It's a key area of performance, obviously a key area of public concern. We don't have an indicator. That's not a good place to be. So how quickly can we get some steer as to what's going on?
Yeah. Nationally, they were due to finalise all the reporting measures for October. So I can ask for an update on if that was achieved. We were collecting all the data on the health, we were collecting all the data on the social care side, but I think because the measure also includes primary care and the acute trusts, there was some delay in terms of with the acute trust end coming onto the system. So I can check with colleagues in performance if that has now been started to be reported as a national measure. We are proposing to include some of that pathway that's relevant to adult social care, so number of people going home, as part of the measures corporately next year. So that is something which from April we're putting forward to be part of the standard measures that go to Cabinet, and you would of course get the report as it goes to Cabinet, and it can be reintroduced as one of the top measures here. But I will check on if they manage to get all the different parts of the system on the reporting system nationally to enable us to have the full suite of measures.
Yeah, thanks. If we can have that as an action point then, Chair, thanks.
Yeah, that's fine. Maria, is there any other points you need to raise to go through?
We always include the full report for members of scrutiny in case there's any other, particular areas that you'd like to ask us about, but we have run through the red measures and the sort of top indicators that we usually talk to.
Okay, can I ask members, are there any other points that they want to raise with Maria while she's here? I'm assuming not. So can I thank you, Maria, for the presentation. It's been really useful as always. And if you could sort of have a think about how we could adjust the presentation to pick up the points that Councillors Pocock and Fowler raised, that would be really useful.
We will do. And we're very happy to meet, specifically if there are particular discussions that members of scrutiny would like to have around the measures.
Thank you, Maria. And as always, thank you.
Thank you.
Thank you very much. Okay, committee. So we're next moving on to the work programme. So do members have any comments on the work programme that can be noted or potentially adjusted? I assume not. Okay. Request call in, counter call for action, petitions, etc. I assume potentially, since there's no hands up, I'm assuming no again for that.
Chair, just very quickly, apologies, just if on the work programme, if we feel that something we think should come forward. Could we come back to you at a later date, please? Should we?
Of course, yeah. I mean,
thank you, Chair.
We've got a little time at the end of the municipal year, but by all means do that. I think in terms of any other urgent business, there was an issue, I think, that Councillors Fowler and Pocock flagged up earlier in the week regarding a informal meeting they'd have regarding day opportunities. We're fortunate enough now to have a date that's been sent out to people for a further informal briefing. I think it would be from John Williams, etc., for the 1st of March, which people hopefully will have in their diaries to follow up from the work he did for us in November. Obviously, we don't have time for a detailed feedback, but I wondered if Councillors Fowler and Pocock, again, in brief comments they wanted to make regarding the informal meeting they actually had. But if you do, Ben, if you could keep those really brief.
Go on, Rob, you go first. I can see it.
Very brief. It was a very helpful, insightful presentation, and I look forward to the detail coming on the 1st of March, and I agree with your proposed actions, Chair.
Yes, and I would concur with what Rob said, and we had a good meeting with John. Found it very informative, and if it's going Cabinet going to June/July, it's still helpful to have that meeting in March. So we very much welcome that and support you, Chair. Thank you.
Okay, it's my pleasure. Okay, authority to chair an office. Can I have your authority to act in any urgent situation between meetings? Okay, thank you for that. And the last point, I wanted to thank everybody for the time and their input today, which has been really appreciated by myself. It's been a really interesting session, and to wish everybody a happy and safe Christmas and a pleasant New Year. So thank you everybody for your time. I appreciate it.